PNOC informational webinar for Pediatric Craniopharyngioma, the fourth in our series of pediatric disease-specific tumor type webinars. I'm Bruce Campbell.
And I'm Alan Campbell, and we helped co-found PNOC Foundation in 2013, just 3 years after our son was diagnosed with a brain tumor.
Thank you to viewers for joining us from both near and far. Today you'll be hearing from our world-renowned PNOC doctors specializing in craniopharyngioma about the current state of research, clinical trials, and treatments for this tumor type.
And you'll also meet a patient family and hear her story and her insight. The purpose of today is really information sharing, and we've got a wide range of viewers, from families that have just been newly diagnosed to those families that have been really tackling the disease for some time. And we really want to hear your questions, so we encourage you to put your questions into the Q&A.
For those of you joining us for the first time, the Pacific Pediatric Neuro-Oncology Consortium, or PNOC, is one of the leading global pediatric brain cancer consortiums with study sites within the US, Canada, Europe, Australia, and Israel, striving to improve outcomes through a unique collaboration of doctors, scientists, biologists, multidisciplinary practitioners, translating the latest findings in brain tumor biology into clinical trials and more effective treatments. A key mechanism to support the translational research is through this unique approach of the disease-specific PNOC working groups, which include investigators from around the world with specific tumor type expertise and focus. Through scientific collaboration and consensus, the most promising clinical trials are developed. Advocacy and philanthropic groups are also invited to lend their perspective and partnership.
Yeah, and PNOC Foundation is a nonprofit foundation really led to help support fundraising, awareness, and really everything to support the PNOC Scientific Consortia so the doctors can do what they do best.
Without further ado, it's a great honor to introduce our distinguished panel. Dr. Fatema Malbari, Director, Neuro-Oncology for the Division of Neurology, Assistant Professor, Division of Pediatric Neurology and Developmental Neurosciences at Texas Children's Hospital, Baylor College of Medicine. Dr. Cassie Klein, Attending Physician, Director, Neuro-Oncology Clinical Research, Courtney Rose Foundation, Clinical Researcher in Neuro-Oncology, Division of Oncology, the Children's Hospital of Philadelphia, Director of PNOC Data Quality and Integration, and Dr. Maya Lodish, Selma L. Kaplan Chair Distinguished Professorship in Pediatric Endocrinology Diabetes, Professor of Pediatrics, UCSF, Department of Pediatric, Division of Pediatric Endocrinology.
And Dr. Nalan Gupta, Chief Division of Pediatric Neurosurgery, UCSF Benioff Children's Hospital, Professor Neurological Surgery, UCSF Weill Institute for Neurosciences, and Dr. Shannon Lundy, Pediatric Neuropsychologist, Associate Clinical Professor, Department of Pediatrics, Director of Psychology Services, Neurodevelopmental Program Director for the CRS-CTSI Neurodevelopmental Assessment Program, UCSF. And in addition to these doctors, we also have some esteemed doctors joining us to help answer some of the questions. Dr. Sabine Mueller, PNOC co-founder and project leader, Assistant Professor of Clinical Neurology, UCSF, and Dr. Michael Prados, PNOC co-founder, Emeritus Professor, Charles B. Wilson Professor of Neurosurgery and Professor of Pediatrics, Neuro-Oncology. We're also really joining family guest Amy Wood, Executive Director of the Ray May Wood Foundation, whose son Alex is a craniopharyngioma survivor. And last but not least, we have PNOC Foundation team member Rachel Cassels, who will be helping with the moderating.
So I'd like to open up our questions with this first one directed to Dr. Fatema Malbari. Dr. Malbari, how is this brain tumor type different from other types, and how does this affect treatment and treatment approaches?
Sure. We have some slides that we were hoping to review, which may be helpful to have a visual. But craniopharyngiomas are considered rare brain tumors that affect both children and adults. They are low-grade tumors with long-term survival. However, due to the tumor location and the characteristics of the tumor, patients with this diagnosis can often have devastating side effects. So in children, you can see that the tumor is often solid and cystic. The cyst is the darker filled fluid-filled spaces, and are frequently adenomatomatous subtype. And the tumor itself is often located near critical structures such as the hypothalamus and the pituitary gland, which are responsible for hormone regulation. It can be in close proximity to the nerves of the eyes, leading to vision loss. It's also very close to critical blood vessels, and therefore these patients are at a higher risk for stroke. And in general, it can affect cognition and memory as well. The location of these tumors makes the treatment somewhat challenging, and surgical intervention can be challenging and can often lead to similar devastating effects. Treatment of these tumors, when able, is to remove this tumor entirely as safely as possible. Another effective treatment for these types of tumors is taking part of the tumor out and following it with radiation therapy. Radiation, however, also has its own side effects, such as an increased risk for stroke, secondary cancers, hormone regulation issues, memory and learning issues. And the other challenging part about these tumors is that there are different tumor compartments, like we mentioned. So oftentimes the cyst portion of the tumor can be more challenging to manage and is not treated as effectively with some of the treatment that we have. And the therapies that we do have do not completely remove the risk of these tumors coming back. In about a third of patients, these tumors can regrow within 3 years of diagnosis. I think what's really challenging is because these tumors are so rare, the lack of knowledge about what causes these tumors, what leads to them growing back, and the rarity of it, treatment options are limited, as opposed to some of the other low-grade tumors where we have more information about the biology and we have additional therapies that we can try. I think what's exciting is that the current state of research for this tumor has allowed us to identify some potential pathways that can be targeted for treatment in the future, and hopefully we'll hear about that in a little bit.
Thank you. It was interesting when you went through the progress of that. I think it makes sense to go to Dr. Gupta now, because he's the neurosurgeon and really talking about that uniqueness of this particular tumor type in that position. And can you share how this impacts your surgical approach?
Yeah, thanks for the opportunity to join the group today. Well, actually, as Fatema said, the challenge surgically is really the two aspects of the tumor that are the location, meaning that it's nestled often between the optic nerves, immediately above the pituitary gland, and then immediately below the hypothalamus. And so we can get to this area surgically through actually a variety of approaches, but it means that the risk to these structures, even if they aren't damaged by the tumor, we can injure those structures. So the risk associated with surgery is just, number one, is just the location being very, very important with respect to those three major structures. The other aspect to it, which I think is something that we've really appreciated, I think, in some ways over a long time, but more recently, is that, as Fatema also said, is that we consider these as low grade, meaning they're not a cancer, what people call cancers. But on the other hand, the way that the tumor grows is that it often, not in all cases, but in many cases, will be what we call sticky. And by sticky, I mean that the side or the edge of the tumor is not easily separated from the normal brain or the normal blood vessels or the normal optic nerve. And in reality, what happens is that the wall of that tumor, where it's sticky, the tumor will grow into the normal tissues. And sometimes, even if you are able to remove the tumor, little islands of tumor will remain behind. And those two factors make complete resection of these tumors difficult safely. You can remove them, certainly, but you don't want to do that at the cost of causing really unacceptable disabilities to the patient. So that balance is what, I think from not only a surgical side, but a treatment side, we struggle with all the time. Even in surgical series where surgeons have tried aggressively to remove all of the tumor, and the postoperative scan looks great, you know, as high as 30 or 40% of those patients will still have a recurrence after surgery, even if the surgery goes extremely well.
Thank you, Dr. Gupta.
Yeah, thanks for sharing that. Next question, I think, is for Dr. Meyer-Lodish. So, Dr. Lodish, we've heard about the tumor's location to the critical structures like the hypothalamus and the pituitary. How does that typically manifest in terms of endocrine disruption post-treatment?
Sure. Thank you so much for the opportunity to speak and for the question. So at the time of diagnosis, often the location of the tumor itself can lead to endocrine deficits that are part of the child's presentation, such as polyuria, polydipsia, meaning that the child has diabetes insipidus or a poor growth trajectory is noted, or potentially amenorrhea, for example. So there's a lot of different factors that affect the likelihood of having an endocrine deficiency with the craniopharyngioma. So those include the location of the tumor, whether it's supracellular, intracellular, or extending into the hypothalamus. And as Dr. Gupta mentioned, the type of surgery. So whether there's a gross total resection or a cyst drainage where you're able to preserve hypothalamic integrity, you'll have less late effects, specifically severe obesity related to hypothalamic damage. And then whether or not there's a recurrence affects your likelihood of endocrine deficiencies, and also cranial radiation therapy. So the dose and the location of the therapy, we know a lot from surveillance of children after receiving radiation about the risk of developing anterior pituitary deficiencies. But it's a joy to partner with families and patients to help to manage these late effects together.
Thank you. Let's kind of go back and we talked about the rarity and how there's not a lot of information on this right now, but it'd be good to hear from Dr. Cassie Klein about the state of the disease 10 years ago, kind of what we're knowing now, and like to hear that.
Absolutely. I think that, we've been really fortunate in the brain tumor space globally over the last several years because we have had the advent of technologies like genomic sequencing and protein analysis and a number of ways in which we're now interrogating tumors in the central nervous system to help us figure out why they happen, potentially why they come back, and are there therapeutic vulnerabilities that we can capitalize on when we're thinking about how we should best treat these patients and target these tumors. And so what I'm showing here is really how far we've come even in the last 3 years, honestly, in terms of craniopharyngioma. So you'll see on in the green circles, this ACP kind of column, and this is the adamantinomatous type of craniopharyngioma, which most commonly affects our patient population. And essentially what we have found by looking at the molecular characteristics of these tumors, whether or not they carry these alterations in a region or a gene called CTNNB1 or BRAF, that really helps identify and segregate these tumors to be different types of craniopharyngioma. Additionally, even within the adamantinomatous or the pediatric type of craniopharyngioma, we're now understanding that there's different pathways and different types of activity within the tumor itself. And what's so exciting about this is that these pathways that we're identifying that are active are actually targetable by contemporary types of therapies that are out there. And the interesting part, even more so about craniopharyngioma, as what Dr. Gupta and what Dr. Malbari described is, this kind of two-component nature of the tumor. We have the cystic component and we have the solid tumor component. And historically, we've either utilized things to kind of target the cyst or potentially like surgical or radiation-based approaches to target both regions. But as we're finding more and more about the components of these different regions of craniopharyngioma, we're understanding the basis in terms of what is potentially driving these different areas and these different regions of tumor. And again, with the development of novel therapies, we can actually start to think about how we can best bring treatments together and target these different parts of the tumor, and then globally craniopharyngioma itself. And ideally, you know, hopefully this is moving us away from where we have traditionally utilized surgery, trying to be as aggressive as possible, in some cases getting out as much tumor as possible, and radiation, which we know are good treatment options in terms of removing the tumor or ideally decreasing the chances of it coming back. But as was already described, come at their own cost. And so I think where we are today versus kind of where we were 5-10 years ago is really paramount in terms of our understanding of these tumors and what is potentially driving them, and ways in which we should be being thoughtful or more novel in targeting them. And so I think that that is honestly a really pivotal point. I'm hopeful as to where we are today versus where we have historically been, and hopefully where we will continue to go.
Thanks, Dr. Klein. Let's go to Rachel for some questions from our viewers.
Hi, everyone. We actually have a first question for you. Can children with a craniopharyngioma present without endocrine deficiencies at the time of diagnosis? Are there endocrine deficiencies that are more common at diagnosis?
Yeah, absolutely. That's a great question. So not all children with craniopharyngiomas present with endocrine deficits. The rate of prevalence is about anywhere between 40 to 87% in the literature. And the most common endocrine deficits at presentation would be a growth hormone deficiency, so a trajectory of growth that's slowing, followed by a central hypothyroidism, and diabetes insipidus, which is related to the posterior pituitary.
Thank you. We also just had a question that I know Sabine answered in the written form, but it was about the difference. It sort of touched on the difference between adult and pediatric presentation. Does anybody want to comment on that?
Sure, I'm happy to. I believe that the question was kind of the different effect of the tumor in this patient population, correct? Yes, great. So, I mean, I think in terms of the specific question in regards to where these tumors are and potentially the side effects of the tumor itself, where it's located, and the interventions to treat it can be very similar in terms of the adult and pediatric population. The timing with which and the impact of that injury, though, can be very different in terms of if you're impacting a child in the prepubescent or periods of kind of rapid growth, then potentially that impact can be very different, and Dr. Lodish can talk to that. And then in terms of just the different types of subgroups, the papillary versus the adamantinomatous, we are finding that these tumors themselves can perhaps behave similarly, but that the pathways and the targeted approaches may be somewhat distinct and or in certain cases overlapping. And so we are certainly partnering right now with some of our adult colleagues in some of the treatments that they are bringing into the adult space, and ways in which we can kind of collaborate and work together to build on the information that we are collecting in parallel and coming up with cohesive, improved therapies across the board, really.
Great. Thank you, Cassie. Another question from the audience is really about sort of what is on the horizon for therapies. And one of the questions I think that was asked in few ways is really, what do you see as the most promising sort of path forward in terms of therapy and the role of immunotherapy? And obviously the concern that we've seen in other pediatric brain tumor types that immunotherapy could maybe work, but is potentially short-lived, and obviously also comes with significant toxicities in some populations. So maybe Fatema or Cassie, if one of you could comment on this, or both.
Sure. And I can actually pull up a little bit, another slide and diagram, and maybe I'll kick us off, Dr. Malbari, and then you can take over. But that's absolutely right. As you know, we are really hopeful that immune-based therapies can potentially be a targetable approach in craniopharyngioma. And this is based on, like we just talked about, kind of the pathways that we've found to potentially be active and or driver alterations or driver components to these tumors. And so right now, one of the collaborations that we're doing with basically everyone on this call and then extending beyond really globally is bringing together two types of drugs. One, which is a drug called nivolumab, which is an immune-based therapy in combination with another drug called a pan-RAF inhibitor, which is another type of pathway inhibitor. And we're really hopeful that by bringing these two types of drugs together, we're going to potentially be best able to target the cystic and the solid portions of these tumors, and ideally come together to prevent or delay things like more aggressive surgery or radiation, which we know have side effects. However, we want to do so in the most thoughtful way possible, and in ways that are going to continue to inform how we can grow and develop better treatments for these patients. And Dr. Malbari, maybe I'll let you walk through the design a little bit, and maybe some of the ways in which we're being novel in the statistical design of these trials too.
Yeah, so we're opening this trial to patients who have both newly diagnosed craniopharyngioma as well as patients who have recurrent craniopharyngioma that have been previously treated and are looking for other treatment options. And so basically, for the patients who we think have craniopharyngioma, before we do any surgical intervention, as long as it's not indicated or necessary or emergent at the time of their diagnosis, we're going to confirm that their imaging does truly say that this patient has craniopharyngioma. And then our goal is to give the treatment and then do surgery to look at the effects of that one dose of therapy on the tumor tissue and see if we're actually getting any response, and learning from just even that one dose of the treatment to the tumor tissue, followed by continuing on the therapy either after receiving biopsy only or a partial resection. Patients who get a gross total resection will not go on to receive the combination therapy, but if you're getting just a biopsy or a partial resection, you'll go on to receive both treatments with the PD-1 inhibitor as well as this pan-RAF inhibitor. And so again, the goal or this unique design is to really, one, confirm that the treatment is getting into the tumor tissue and to see if we can see any effects. And so that's why we're giving the dose prior to them having any surgical intervention so that we can have that additional information. And then, we were trying to see what we should focus on in terms of our goals or outcomes for this particular trial. And I think that, just in discussion, one of the things that we felt we wanted to make sure that this novel treatment approach would continue to do is that we didn't want patients to have tumor recurrence earlier than would be expected for receiving standard therapy. So we're going to look at patients at a year out and make sure that the time to tumor progression does not actually come sooner with this type of novel approach. And in addition, one of the things that just talking to our patient advocacy groups, one, really important piece of information that we learned was that quality of life is so important to patients, and that it actually can be affected as early as a year into therapy for patients who have craniopharyngioma, and in particular your physical function. And so we want to make sure that we maintain that physical function score at about 12 months as well, to ensure that the treatment that we're giving is not causing any additional concerns or issues that families would then need to worry about. So these are kind of the two goals that we're looking at for our particular trial.
Great. Thank you. I think to summarize this, right, you can basically say that you're just starting to learn about how immunotherapy will be really applicable to craniopharyngiomas. We are very excited about this. But I think some of the questions like, will it really work, to how long it will be effective, I think this is something that we are trying to learn as part of these new studies that Dr. Klein and Malbari just have introduced. Another question that is what came from one of the patients, and I want to address this to Dr. Gupta and maybe to Dr. Malbari, is a common problem we have with these tumors, sort of response to radiation, but then often cyst growth afterwards. And what have we seen and what do we know in terms of response to radiation therapy in these tumors? And then what are good options, if there are any, to deal with something sort of cystic changes more than basalic changes? I think that is a problem that many families face and we face obviously from the clinical side as well. So maybe Dr. Gupta, you could start. Yeah, no, it's an important question. I think if I had to group, craniopharyngiomas are, when we can manage them successfully, are really the ones that we can manage, whether it be by total resection or subtotal plus radiation. There's a group that respond well to that and don't come back. But then there is a substantial percentage in both categories that recur. And it's the recurrent craniopharyngioma, whether it's solid or cystic recurrence, that are a very difficult challenge to manage. The patients that have already had radiation therapy, it's really what we, in kids, we try to wait until the end before we plan to use radiation therapy. By end, I mean end of sort of our usual treatment options, because we want to prevent those long-term effects. Now, a 15-year-old is very different than a 5-year-old in terms of the potential effect of radiation therapy. So age plays a huge role in that decision. When we have cystic recurrence after radiation, we try to manage that with a combination of surgery and sometimes intracystic, or agents that are delivered within the cyst. One of the limitations we've had is that some of the agents that have been used with some success in the past are no longer available. For example, at one time, intracystic radioactive agents like P32 were used with some success. We don't have access to those anymore. Interferon now is no longer available, and it was also something that some groups had some success with. So we've been really forced to rely upon, I think, the limited number of intracystic agents that we have and surgery in that specific setting. But I would be honest with you and say that recurrence in that setting is a challenge to manage, both not one time or two times, but these tumors tend to recur multiple times.
Yeah, I completely agree with Dr. Gupta. I think the cyst component of the tumor is so challenging to manage. And it's one of the compartments of the tumor that with radiation can definitely not respond as well. And oftentimes surgical intervention needs to be used to control the growth of the cyst. We are, again, are hoping for newer treatment options, and there is some data to suggest that the PD-1 inhibitors that we are using may target the cyst lining of these tumors. So that may be a new approach to manage these tumors in the future. But at the current moment, it is really challenging to manage the cystic component of these tumors when they come back or not respond to radiation.
Great. There's one question which I think we often get, and this is for Dr. Lodish. The question, obviously, a lot of our patients need growth hormone replacement. And the fear in that setting is always, does that stimulate tumor growth? And is that a concern we as physicians, but obviously also families have? I was hoping you could comment on this and what your practice is and has been.
Absolutely. Thank you so much for that question. So clearly, as a treating physician, you really never want to cause harm. And this has led to a lot of surveillance and long-term studies of children with different types of tumors who are treated with growth hormone, looking at potential risk of recurrence of the primary tumor in those treated with growth hormone. And the wonderful news is that fortunately, and particularly for benign tumors such as craniopharyngioma, there does not appear to be any increased risk of tumor recurrence in those individuals that are treated with growth hormones. So it is considered quite safe. There's still controversy among experts about how soon after treatment is completed, is it safe to start growth hormone? And I think my practice is with craniopharyngioma, even starting as early as 7 months to a year after treatment's completed, especially if you're in a window where the growth of the child is so important, but obviously with close communication with oncology team and surveillance. And also with titrating the dose closely so that you're making sure to have the growth hormone at a very safe level.
Thank you. Really good information. And I think it'd be great to get that patient perspective kind of going through this whole journey. So I'd love to ask this question to Amy, if you could share a bit about your son's diagnosis and treatment and kind of what inspired you to be here today.
Sure. Thank you for having me. So I'm 6 years in, my family is 6 years into this journey. My son, Alex, was 4 years old. We had no inclination that anything was wrong until literally the day he was diagnosed. He woke up, it was May 2015. His left eye was crossed inward. We thought that was strange. And that night around 6 p.m., we ended up at Johns Hopkins in MRI to diagnose a mass in the middle of his brain. So that was a very life-changing day. As he went into emergency surgery the next morning, he was having hydrocephalus and concerned about the tumor and the vision situation. So he went into surgery, and we came out 10 hours later and started learning words like diabetes insipidus and so forth and so on. Our biggest challenge post-surgery was the diabetes insipidus. So he was losing quite a bit of fluids and kind of, teetering back and forth between high and low sodium. So he was in the hospital for about 2 months, PICU for 4 weeks. And then we had some subsequent hospitalizations that year for the DI management. So he had a craniotomy, gross total resection. We've had no recurrence, fortunately, so that's been great. However, with the DI management in the first year, we were in and out of labs quite a bit, in the ER, airlifted 3 times back to the mothership in Baltimore. So we had determined that there was a handheld blood analyzer in the hospitals, used in hospitals, that could allow us to potentially measure his sodium and manage his condition at home. We procured that device, were able to successfully put it to good use, keep him out of the hospital for a good year or so. And so we started the foundation, the Raymond A. Wood Foundation, to purchase and distribute those devices to other families who have difficult to manage diabetes insipidus, and have since grown to sort of focus on the quality of life issues that face craniopharyngioma patients and survivors. Most notably right now is a dipstick DI, so the DI without thirst mechanism to manage it, and hypothalamic obesity, which are the two of the major quality of life issues, in addition to social and cognitive issues. So that is where we are. I mean, 6 years later, he's doing fine. We've had 1 year, no hospitalizations. He tends to get hospitalized for hypothermic seizures in the winter. So he has a temperature dysregulation issue. So that's another big challenge for us. But overall, we're been in this journey for a little while, and I see some familiar faces in the attendees. So a lot, we all share our stories on Facebook and work with each other through the Facebook group and try to provide support there.
Sharing that, incredibly inspiring, all that you did for your son and for the other patient families. It's truly remarkable. Thank you for sharing that.
Alan, I have a question. This is Alan here. I have a question for Amy. I just wanted to hear from you. How did you communicate with your son about all of this? I know obviously he was younger and is now several years older, but I'm curious to hear how you educated or told him about what he had.
Well, he was 4, and it was so sudden. And I had, my husband and I were so just blindsided as well. So we're all in the emergency department at Hopkins and just trying to understand what happened. So I know a lot of people in this journey, they get diagnosed and they have some time, the children get diagnosed and there might be some time to process, get some other opinions. We had a quick turnaround. I remember my son being in the PICU the next morning awaiting surgery. And he said to me, "Mommy, am I sick?" Because he didn't understand. Yesterday he was in school. Today he's in the hospital. So it was, his age is a pro and a con in that his age, he was too young to know life before. So this is his life. He takes the medication. Sometimes he has to go to the hospital. This is kind of how his life has been. So we talk about it. He knows he's a brain tumor survivor. He's very diligent about taking his medication. So it's, age in that case was helpful in him being able to accept the situation. I see some of the older teenagers and young adults and even 10 or so on, it's a little more challenging because they have life before and life after. But for him, it's been this has been all he remembers.
Thank you. I think
Definitely
that,
sharing that.
yeah, it's amazing the advocacy you do as a parent, and really something that we have to take care of for their lives. So thank you. And that really ties me to the next thought too. And this is really for Dr. Lundy, because as these patient families really are challenged with these quality of life and these deficits, post-treatment, really would like to hear from you, like what types of information that, what do you learn from each patient and how do you help the patient families deal with this?
Thank you, Alan and Bruce, and thank you. It's so wonderful to be with this great group of clinicians and researchers and families that are willing to share their stories. So I think that, just as we heard from Dr. Malbari and also Dr. Gupta alluded to, from the actual surgery itself, we know that there can be physical deficits. And so and Dr. Lodosh has spoken to that as well. So those are important things to obviously treat, but that then impacts social, cognitive, and kind of overall emotional functioning going forward. And so there are a couple different things. I mean, we do know that there can be neurocognitive effects related to just even surgical resection, but often it's more related to radiation. And there's a core set of cognitive processes, particularly in patients who have had radiation, attention difficulties, and that's kind of a divided, sustained attention, working memory, being able to hold on to a lot of information at once and do something with it, and or just in general acquiring new information, just taking a little bit longer to do that. And then cognitive efficiency in terms of getting information out. And so there are lots of different kinds of supports that children can learn early on to address some of those things. So I think the importance of having, neuropsychological evaluation once your child is done with treatment and is, stable and doing better can be very helpful. And at different times in development, that can be really helpful because recommendations will change. So understanding the neurocognitive strengths and weaknesses that the child has and what specific tailored recommendations they're going to benefit from at school, learning is really important. And those will change over time just because demands change in terms of what they have to be able to do. I think for some of these patients, there are visual deficits. And so making sure that there are the right things in place at school to support vision impairments in terms of where they're sitting or which side of the room, things like that. All those little things actually make a big difference. And I think particularly for this patient population, since the quality of life and physical effects can be so challenging, that's a huge piece to address. So certainly, as Mrs. Wood was sharing, this is all her son has known, but especially for kids who are a little bit older and they have this huge change and shift in their life, it can be really, really hard to adhere to the fact that they now have to take these medications, especially the endocrine issues, and that they're kind of long lasting. It can be really challenging to work as hard as you can, but then still have this weight issue. And so you have this social and physical isolation because you're not able to do the things you once were able to do before. And that can be really challenging for families. And so really working with your medical team, as Dr. Loder said, we really want to team and have a multidisciplinary collaborative approach to try to make adherence issues not a challenge. If kids are feeling those kinds of differences, what can we do that they can now do that's a different thing that they maybe possibly participated in before, talking to schools and their peers about what's now going to be a challenge for them, but how we can work around that and make it different, but still better and still positive are all things. So I think working with the team of clinical psychologists for therapeutic and adherence issues, neuropsychology to make sure you can get a really good handle on the school supports and needs that they have. And I think just also working with the family and being there and present for the different challenges that are going to arise over time is something that I think all of us really want to do and want to be a part of, because it does change with development.
Yeah, look, I've got to say to the viewers, our son's a brain tumor survivor. In this case, he had an anaplastic ependymoma, and as you go through treatment, a pediatric neuropsychologist is probably the last person you're thinking about. But Dr. Lundy's care for him has been invaluable in terms of integrating him back into the educational arena and creating a scaffolding around him that has enabled him to be very successful academically and to maintain his self-esteem. So, just wanted to send a shout out to you for all your help and support. And this weekend he's sitting for an ACT exam. So it's quite a milestone in our household. So thank you. Look, this is a question generally for the panel. Look, we all know that, pediatric brain cancer is, incredibly under-resourced, underfunded. But really, we're sitting here with a panel who are really at the forefront of what is happening and probably have the best view of what is possible. I know that in the last, 5 or 6 years, you've learned more about the biology of the deadliest childhood brain tumors than in probably the last 40 or 50 years combined, and using that knowledge to translate into, better clinical therapies. What do you, in the context of what you know about the progress you're making in other brain tumor areas, what do you think, or what would be your vision for what is possible, in this area of craniopharyngiomas, over the next 10 years? So, I might pick on you, Sabine.
I think what we're striving to do with all brain tumor subtypes is really to tailor the treatment as best as we can for these tumors. I think what Dr. Klein was showing, right, we are now segregating these tumors. We understand the different subtypes. We are trying to really understand what's driving these tumors. And I think we will learn this over the next few years. And I think that will dramatically help us, right, to design better therapy trials and to hopefully reduce some of the burden that some of these children obviously have as long-term side effects from surgery as well as from radiation therapy. So my hope would be, with understanding more about the biology and the details and the different subtypes that most likely we will discover with time, that then we have better therapies available that can hopefully reduce really some of the morbidities we see with recurrent. And our therapies for these tumors really hasn't changed at all over the last decades, right? It's surgery and radiation, and then we are trying different, like interferon, etc. But none of this has been really a breakthrough for these tumors. And so I think reducing really the morbidity from the tumor location itself. And then the other area, which I think was addressed a little bit by Dr. Malbari and Dr. Klein, I think in our clinical trials, we not only aim to focus on the tumor and the tumor progression, but really also looking at these functional endpoints, right? I think it will be so critical to assess this in more detail. And I think that will also help us to develop better strategies. And then obviously what Dr. Lundy touched on, I think a huge investigation of our work, and that I think is specifically applicable to craniopharyngiomas, where the mortality rate is really low, which is great, but the children suffer from a lot of side effects, is really identifying also better therapies to help with some of the consequences, like the cognitive issues. And I think there's great work, and Dr. Gupta is also working on some of this, really trying to also think about better strategies after the initial tumor care. So I think that would be definitely my vision for the next 5-7 years. And I think with sort of the trial designs that were brought forward by Dr. Malbari and Klein, I think this is exactly what's addressing sort of the first portion, really trying to identify the functional outcomes, but also looking at the different subtypes, understanding the biology better.
And
Sorry.
Yeah,
no, I was just going to add to that is that I'm optimistic. I think that if we look at year to year, often you can get very frustrated, but if we look at what has happened in probably even just a generation in, for example, the management of breast cancer, our grandmothers who had breast cancer, had a terrible outcome. And, in 2 generations later, there's still women that have poor outcomes, but the survivors with that disease, there's been a tremendous change. In children, the success has been with the liquid malignancies, leukemia, lymphoma, which, many children used to die from 2 generations ago. So, that doesn't mean it takes us generations, but it means that each type of tumor has a weakness. And our challenge is to find those weaknesses for craniopharyngioma. There's some glimmers in there. We mentioned interferon. I have a patient who had a very complex craniopharyngioma that 90% of it, disappeared with interferon alone, and has stayed that way for a couple of years. Now, does that mean all are going to respond to that? No, but we don't even understand why hers responded like that. So our challenge is to understand these weaknesses in these craniopharyngioma, and they're different. One tumor responds in one way, other tumor responds in a different way. We don't understand those differences. Whereas in breast cancer, we do. We understand why some, tumors respond to therapy and why others don't. And I think that's our challenge for the next 5-10 years, is to figure that out and to be more intelligent with our therapeutics.
Can I make a comment? I think I'm very optimistic as well. I think for rare tumors and rare cancers, it's a different scenario to some degree. And in order for us to get to that place where we're going to be like breast cancer or lymphoma, we actually have to be better at sharing data in real time. And that actually is the point of this webinar, but also the working groups and the idea of a PNOC and the CBTN and other groups where they're trying to give information, but also get stuff back, both from the patients and the families, but also from researchers around the world, and everything that we can gather together in as quickly and as efficiently as possible, so we don't have to wait 8 or 10 years for each trial to come to fruition. And I think people like Sabine and Cassie and others are trying very hard to change the way we do what we do. It's not the standard approach anymore, and we can't keep using these standard approaches for clinical trials to come to the understanding of, do our therapies work or not. So we have to actually take into account the opportunity of data and how to use data and how to aggregate data and how to share data and use it wisely, so that we don't spend 2 more decades to try and get an answer to the questions that we have. So that's what the point of all this is, I think, is that we just have to share data better and more efficiently and get the resources to make that happen.
Great, but tailing onto this, I have a question for Dr. Lodish. I mean, I think a huge component, obviously, of a long-term effect is sort of the endocrine dysfunction. And what do you see really on the horizon? Is there anything exciting that you think would maybe make that easier for our children and young adults? Anything coming down?
In terms of therapeutics?
In terms of therapeutics, maybe better administration routes. I mean, anything that is sort of...
Well, one on the horizon, we're about to get FDA approval for a once-weekly growth hormone injection instead of having to give daily injections, which is exciting. But I think, I mean, I really think it's important to empower families to understand the risks for developing these different late effects and providing more education about, you know, management at school, and so that it doesn't limit what a child, you know, is capable of doing in their day-to-day lives. But I'm part of some exciting consortiums with the Children's Oncology Group and even with international groups that are looking at late effects in survivors of brain tumors. And I think as new therapies emerge that are potentially more targeted and less, I mean, it's difficult, I think, when the standard of care is surgery. It's hard to not do that and do watchful waiting. But I think craniopharyngioma is a beautiful example of a benign lesion where we could really make headway with some of these newer agents. And so hopefully you'll put me out of work and I won't have, to have a lot of endocrine late effects.
I'd love to jump in here just because we've been doing a lot of work at the foundation for some of the side effects, especially hypothalamic obesity. There is a clinical trial opened up. Rhythm Pharmaceuticals is trialing setmelanotide, yes, and that's opened up. So that's something that is on the horizon. We're also meeting with the FDA to get a better understanding around hypothalamic obesity as a condition that needs a treatment, since that's one that's, you know, and the Raymond A. Wood Foundation is partnering with CHOP, right, in moving into phase 1 proof of concept of an at-home sodium meter. So there's some things we're working on that hopefully too will bring in some additional support for some of the long-term effects of treatment and this tumor.
Amy, I'm so excited to hear about your work and the advocacy for an at-home sodium meter. It makes so much sense, and facilitating getting that in the hands of our patients. I mean, I take care of many, many children with diabetes and they have a continuous glucose monitor. So why can't we, you know, empower our patients and have the knowledge instead of doing all this guesswork? It's just, I would love to bring that to more patients and partner with you.
It's a long, it's going to be a long road, but we're almost to phase 1 of that road. So we're really excited, I think. And we're optimistic that it can be something that's doable and in the hands of patients, FDA approved, covered by insurance. Wouldn't that be amazing?
It would be amazing. Yeah, and we absolutely need more effective treatments for hypothalamic obesity. It's really a very, very challenging, and there's nothing that is a slam dunk so far.
No, good. I think, you know, just in hearing this kind of conversation too, or, you know, the both of you are talking about how these families could kind of better manage it. So I think this question is both for Amy as well as Dr. Malbari, is what advice do you have for those families that have a newly diagnosed patient? I mean, some people are just joining us, and what some of this conversation is things that could happen further on. So kind of nice for them to hear, like, what would you share? What would you, for a newly diagnosed family? Maybe Amy, I'll start with you first, then we'll go to Dr. Malbari.
Sure. So, you know, information is so important, and I think arming yourself with as much knowledge, but understanding that everyone's path in this is very different. I don't think I've seen any blueprint for craniopharyngioma and its after effects. So sometimes when you're digging for information, it can get scary. And I think that, so I always caution newly diagnosed to kind of take everything with a grain of salt. And at the end of the day, the ultimate question should be answered by your medical providers. The Pediatric Brain Tumor Foundation has a wonderful peer-to-peer mentoring program that's really helpful for people. So they will pair newly diagnosed patients with families that have been in it for a while. So that's a really helpful resource. But ultimately, you know, I've just found that the more I know and the more I'm able to collaborate with my son's providers and you know, understand the expectations of all of his providers. And I think that makes for the best long-term result.
Great. We have a lot of questions being asked in the chat section, and I was going to ask if you could pop them into the Q&A section if you haven't, if it's just a little bit easier for us to manage on the back end. Also, not everyone could see some of the responses. So I just wanted to repeat a question to Dr. Malbari about what percentage of patients do or do not have results from radiation post-surgery. If you could, I know you answered it in the chat, but if you wouldn't mind just answering it so that everyone could hear it, that would be great.
Sure. So patients who have a partial resection followed by radiation therapy at about 5 years out, at 70 to 85%, sometimes upwards a little bit higher, will respond to the radiation and not have tumor regrow within those 5 years. So that's sort of what we know based on all of the literature and all of our patient experience.
Also, just a question about trial availability. Will the trials only be in the USA is a question that we have coming through. Maybe Sabine could answer that, or Cassie.
Yeah, happy to. No, I mean, absolutely. We are aiming to open up the trial globally. And certainly PNOC itself has multiple international sites. So we're hoping to make this available at all the PNOC sites. And then we're also collaborating with team members in Germany as well, where we know Dr. Sabine Mueller has a very large portion of patients with craniopharyngioma that he treats at sites there. So we're really hoping to extend the opportunity globally as much as we can.
Ruth, took you a few more questions. Looks like there was a lot.
Yeah, actually circle back to me in just a minute while I sort through what's been answered and what hasn't.
One of the questions that I think would be worthwhile also to answer, and we touched a little bit about it, but what would you recommend right now in terms of getting detailed molecular profiling of the tumors besides just sort of looking for the commonly BRAF alteration? Is it worth doing RNA sequencing and whole exome sequencing? What is your current recommendation? And maybe Cassie, you can answer that. Yeah.
Sure, I think that's a great question. You know, I think at many of our institutions, we have now started to utilize molecular sequencing as standard of care, not necessarily RNA-seq or whole exome, but certainly most of our institutions have a panel of some sort that helps us best categorize the tumors, at least on a DNA level. I think that the utility of kind of doing whole exome or RNA-seq is certainly something that will remain to be seen, and it's in development at this point. It's absolutely something that we're incorporating into our trial, to the points that were made earlier in terms, like what Dr. Prados was saying, and collecting biologic specimens that then we can inform and better understand the tumor and hopefully identify what is and is not helpful in how we manage our patients and treat and diagnose our patients. So, you know, I would say that right now, and the other piece about this is occasionally we have younger age patients that have papillary type tumors. And so we'll find these BRAF V600E alterations, which there are additionally targeted therapies for. And so for those components, I think sometimes molecular sequencing can be really helpful, but the extent and the types of molecular sequencing in terms of the RNA-seq and additional beyond panels, I think will be better understanding of this in the next couple of years.
Great, and I think there was one other question, and I know you have been in close communication with the teams looking at the development of other clinical trials for craniopharyngioma, and one of the questions was tocilizumab. What is your experience? What maybe you can tell the audience around the development of this agent in the care of children and young adults with craniopharyngiomas?
So our colleagues have actually used this drug, tocilizumab, to treat a few patients and have had some success with that. So they're currently in the process of putting together a clinical trial using this drug. And actually, I was just going to check and see if it's opened. I don't know if anyone knows that information, but it is something that's coming up front for treatment of craniopharyngioma as well.
And do you have any experience, you know, have people used it, and have you heard of any experiences using it?
So Dr. Hinkinson probably has the most experience, and he's published at least a case series. they have given it both with and without Avastin, and it seems that it does seem to be effective, specifically for the cystic component of the tumor. And again, you know how we were talking about there seems to be different potential drivers or inflammatory components, and based on if it's cystic or solid. And so the one thing about tocilizumab is, you know, it kind of, we find that the target of that, this IL-6 kind of inflammatory marker, seems to be very, very high in the cystic component. And so, you know, I think that they have had good control seemingly of the cystic component, and now part of the combination approaches and their group, similar to ours, is bringing it together with other drugs that you can target both cystic and solid components and lead to more prolonged disease control than we have seen so far.
So just a time check, I do know that we're reaching the top of the hour. Residual questions in previous webinars, we've posted answers to post the webinar, and I also know this event's being recorded for future reference. I think for anybody who has been voluntarily or involuntarily recruited into the world of pediatric brain cancer, you quickly learn that yes, this is a very rare disease, that it is in fact, you know, the deadliest childhood cancer. And then there's a bright spot to that Dr. Gupta referred to earlier, and it's the success in treatment of leukemia and lymphoma. And so I think really that is the model for pediatric brain cancer and gives us hope, not just hope, but I think there is a reality that we can reach that point. The question is when. And part of that is, you know, inhibited by a lack of data, a lack of collaboration, which is the complete inverse of PNOC and all of the things that you're doing, plus the availability of funds, drugs, and other resources. So I think it's with, you know, deep, heartfelt gratitude that, you know, I convey my thanks on behalf of, you know, all patient families and patients to this panel. You know, there are some bright spots, and I think, you know, this panel is very reflective of one of those extremely bright spots. I mean, your passion, intellect, you know, and tireless work ethic that you bring to this cause every day is what's going to change the outcome of this disease for kids and their families. And the work that you're doing at this time in cancer history is just so incredibly important. So our deepest thanks to you all, and to Amy Wood and to her foundation and the work that she's doing, which will benefit and is benefiting families and will continue to benefit families who are afflicted by this disease. Thank you so much. It's only through continued collaboration and working together as foundations, philanthropists, and as scientists and doctors that we're going to change this. And I think that cooperation is really going to accelerate that change. So thanks to everybody for participating today. And we look forward to convening again sometime in the not too distant future to hear about, you know, exciting updates in craniopharyngioma. Thanks, everybody.
Thank you.
Thank you so much.
Thank you.
Thank you.
Thank you.